A very good day to everyone. My name is MUTHUSWAMI and I'll be presenting to you all about traumatic brain injury. I am a student from OUM, currently pursuing my bachelor's in medical and health science. My matrix number is 89082408 6327001. I am from All-Star Learning Center. Subject which I am pursuing at the moment is NBCP 2424, which is Clinical Practice Pre-Hospital Care and Ambulance Services. My practical area was Emergency Department of Hospital Raja Padmaeswari Bainan, HRPB Ipoh. I'll be presenting to you my case. The patient demographic data. Patient's name was Muhammad Nur Sharif bin Ibrahim. He was 24 years old, a Malay chap, male. His RN was HRPB 2021-054021. The date of incident was 24th of July 2021 at 4:47 p.m. Primary triage. Patient alleged MVA, motorcycle versus Buffalo, attended by PHC team by HRPB at 4:47 p.m. Patient was found unconscious, gasping with stridor and gargling sounds present. GCS was 3/15. Pupils were 4/4 mm sluggish. Vital sign at the moment was 109/76 mmHg. Pulse rate was 107. Respiratory rate was 20 per minute, and SpO2 was 94 under room air. Patient was put on spinal board, cervical collar, and pressure bandage on scalp, especially towards the occipital. And patient was triaged to red zone. Danger. Patient was before reaching to the patient, staff wore PPE, mask, apron, and gloves due to this COVID season. And accident area has been blocked by the police. Patient was found unconscious, so was unable to respond to us. GCS was found 3/15. Airway and spinal protection. Airway was, as we earlier noticed, patient was gasping. There was stridor and gargling sound. Cervical was inline, no spine tenderness. We kept cervical collar due to high impact injury. As for breathing, inspection was done. No distended jugular vein, no bruises or hematoma, no open chest wound, equal chest rise, no paradoxical movement. Breathing was spontaneous, as I said earlier. The respiratory rate was 20 over per minute. Palpation. Trachea was central, not deviated, no subcutaneous emphysema, and chest spring was negative. Percussion, no dullness or hyperresonance. Auscultation, both air entry was equal and lungs were clear, no muffled heart sound. Ventilation, we attached pulse oximeter and SpO2 was 99 under high flow mass. For circulation and hemorrhage control, skin color we noticed it started to look pale, and he still had warm peripheries. CRT, capillary refill test, was normal, less than 2 seconds. Pulse had a good volume. We managed to insert IV cannula intact at 80G size at antecubital fossa. Oxygen was given 15 liters through high flow mask. There wasn't any visible external bleeding. Abdomen didn't have any distended and no bruises. Abdomen was soft and not tender. Bowel sound was present. Pelvic didn't have any bruises, no scrotal swelling, and pelvic spring was negative as well. So disability and neurological assessment. GCS was 3/15. His eye, verbal and motor, and patient's eye was closed. Pupil was Both eyes were 4 mm sluggish. When we exposed the patient, we did a log roll and we noticed 6 cm over 6 cm hematoma over occipital region, no skull depressed, no tenderness, no step of deformity. When we did PR in the ambulance, no high riding prostate, no prominent bone, anal tone was intake. Investigation in emergency department, we noticed his pH is partial carbon dioxide and all his ABG blood was in normal range. Food blood count, we noticed as a slight raise of his white blood cells. Other than that, only a bit of raise in his CK. Others were still normal. Fast scan was done and it was negative, no free fluids seen. Secondary survey was done and we noticed that we wasn't able to get much history from patient and there weren't any relatives of patient. So we wasn't able to get his history of allergy or medication or medical or surgical, even his last meal. Event of injury, we only got few information from the past buyer that patient was still wearing his helmet, but we weren't sure about his speed or mechanism. But he did hit a buffalo. Unsure exact time as well. Physical examination, as I said earlier, 6 over 6 cm hematoma, no bleeding seen for ENT, maxillofacial, no deformity seen, spine, no tenderness, neck, no deformity and no deviated trachea, chest, no open chest wound or no obvious bleeding, abdomen, no distended abdomen, pelvic, no deformity seen, extremis, upper limb, no wound, lower limb, no wound as well, back, no wound as well. Secondary adjunct, CT brain was done. I noticed left frontal contusion bleed and subarachnoid hemorrhage over internal capsule. So we conclude the diagnosis as alleged MVA with severe traumatic brain injury with left frontal contusional bleed and traumatic subarachnoid hemorrhage over internal capsule. Management was done. Prior patient red zone airway was protected with intubation with a size of 7.5 ETT anchored at 22 cm. We capped the cervical collar each time. We support ventilation with a PEEP of 5, tidal volume of 450 at 14 beats per minute. We attach pulse oximeter all the time to monitor the oxygen saturation. We started on IVD 4 pints of normal saline over 24 hours. Vital sign monitoring and cardiac monitoring was done since he was brought into red zone. The GCS charting was monitored as well for pupil size. IO was charted. This patient was sedated under IV midazolam and IV fentanyl. We referred to neurosurgery and we planned for cerebral protection and admitted. We are waiting for a call from ICU. Let us discuss about traumatic brain injury. Head injury is defined as a blunt injury to the head above the neck due to external force with temporary or permanent impairment of brain function, which may or may not result in underlying structural changes in the brain. To define head injury, criteria 1 and 2 must be present with or without criteria 3. So, criteria 1, mechanism, presence of external force. For 2 will be physiological, alteration in physiology of the brain. And third will be anatomical, scalp or face or skull or brain injury, internal and external. Common causes of head injury: vehicle-related collisions involving cars, motorcycles or bicycles, and even pedestrians, falls, spot injuries, and even violence, gunshot, domestic violence, or even child abuse. The secondary survey is particularly important in evaluating patients with mild traumatic brain injury. The mechanism of injury, any loss of consciousness, the length of time the patient was unresponsive, any seizure activity, and the subsequent level of alertness determine the duration of amnesia for events both before retrograde and after antegrade the traumatic incident. Serial examination and documentation of the GCS score is very important throughout the care in all patients. So management of severe brain injury in primary survey and resusc for airway and breathing. We definitely did an early endotracheal intubation. We ventilated the patient with 100% oxygen until the ABG results were obtained. We did use pulse oximeter. It was very useful, and we hope and we always maintain the oxygen saturation above 98, which is desirable. Maintain a partial carbon dioxide of approximately 35 millimeter mercury. Prolonged hyperventilation with partial carbon dioxide lesser than 25 millimeter mercury is not recommended. Reserve hyperventilation acutely in patients with severe brain injury to those with acute neurologic deterioration or signs of herniation. For circulation, if the patient is hypotensive, establish euvolume as soon as possible using blood products or isotonic fluids as needed. We did that. Maintain systolic blood pressure at above 100 Hg millimeter mercury for patients aged 50 to 69, or at least 110 millimeter mercury for higher for patients 50 to 49 years or older. This may decrease mortality and improve outcomes. Neurological examination. GCS score was important. Pupil light response. Focal neurological deficit was noticed. To recognize confounding issues in evaluation of traumatic brain injuries include the presence of drugs, whether we could detect through smell, alcohol, or other intoxicants and other injuries. So we did some other management of giving IMATT because patient had some bruises. We started patient on IV metphenytoin 1 gram, loading dose at 100 milligram TDS. Other blood investigation was also taken. GCS and pupil chatting was documented, and we referred to neurosurgical team for operation and admission to ICU. For conclusion, my personal conclusion is it is important to know how to detect a life-threatening condition regards trauma, especially traumatic brain injury, airway obstruction, tension, pneumothorax, open sucking chest wound, multiple open fractures, massive hemorrhage, and cardiac tamponade. The fast decision taken by the PhD team and to set a large bore granular IV and drip has helped to maintain the circulation, and firm decision to refer the case to red zone shows that they have the knowledge needed to determine the possibility of life-threatening conditions in line to the mechanism of injury. Severe traumatic brain injury is one of the life-threatening conditions. Many patients die before reaching hospital. Early detection and management of head injury can lead to further positive outcome of the patient. The primary goal of treatment for patients with suspected traumatic brain injury is to prevent secondary brain damage. The initial resuscitation will always help in preserving life and quality of life of a certain patient. I individually appreciate the opportunity given by OUM, my program director, Mr. Noah Norris, and the head assistant medical officer, Mr. Benjamin, to the best experience to broaden my knowledge on management of traumatic brain injured patients. Thank you. That's all from me.